Just want to welcome everyone who's joining us. We're just going to give it another minute or so as people enter the virtual room. You see the numbers coming up, so I'll just wait until it gets a little bit more stable. Great, I think we can probably make a start. Others will probably join us when they're able. And what I'd like to do is really welcome you to the webinar today, and thank you for joining us on this webinar about integrating gender equality and social inclusion, or GESI for short, into health programs, guidance, and reflections. My name is Rosemary Morgan. I am based at Johns Hopkins Bloomberg School of Public Health, but I've been working with the UK THET partnerships and the Liverpool School of Tropical Medicine on the GESI integration into health partnerships. And before we sort of get into the meat of the webinar, just a little words about what the UK health partnerships are, in case that is not something that you're familiar with. So the health partnerships are long-term partnerships between UK health institutions and their counterparts in low and middle income countries. They aim to improve health services and systems in low and middle income countries through a reciprocal exchange of skills, knowledge, and experience between both partners in the United Kingdom and in the partnership countries. So health partnerships often begin through an informal or personal connection between individuals and two institutions. And it is the process of widening the connection, deciding to work on a project together, and understanding the need to formalize and institutionalize the relationship that really marks the beginning of a partnership. And many of them seek to address priority gaps and needs that are identified by the low and middle income country partners, and will usually focus their activities on a series of projects. Many of them will focus on the training and development, education of health workers in low and middle income countries, partner institutions, for example. And today you will get to hear from people from two health partnerships that will be sharing their experiences, particularly in relation to the integration of gender equality and social inclusion into those health programs. And I'm really excited that they were all able to join us today. So here is a brief outline of our session today. I will begin with an opening presentation, so situating gender equality and social inclusion. What is it? Thinking about the toolkit that we also produce to help you and others to integrate GESI into their work. Then we'll have a bit of a panel Q&A and presentations from our panelists today, followed by a discussion or discussant for Professor Sally Theobald is here today to act as a discussant, and then we'll move into audience Q&A, and we'll have about 25 minutes for that at the end. A little bit of housekeeping. The event is being recorded and will be emailed out to everyone who registered. Please do at any time throughout the webinar, type your questions into the Q&A function. If you can, please do state your name and affiliation ahead of your questions, so we can hear from where you're from, and ensure that we're hearing from a variety of people today in different locations. Please do keep your questions brief so we can get as many as possible. Do not worry at all about spelling. The questions are coming only to myself and the panelists as well, so that the act of contributing is valued more than the art of spelling. And I know when I type, I often make mistakes. Please do contact me directly if you would like to ask a question, but would prefer to remain anonymous. And again, please make sure to use the Q&A function to ask questions. Live closed captioning is available. You can turn that on by clicking the closed caption button at the bottom of the screen, and you can turn on subtitles or the live transcript. And please do email me with any follow-up questions or points. So here are our presenters, starting off with myself. Again, I am Rosemary Morgan. I'm based at Johns Hopkins Bloomberg School of Public Health. The panel is made up of Dr. Yusuf Ardo from the Faculty of Medicine, the University of Borough City in the Republic of Somaliland. And he is part of the Wolf, Hampton, and Burrow Partnership. Then we have Matthew Nemerimana, who is from Partners in Health in Rwanda, and he's part of the Partners in Health London School of Hygiene Tropical Medicine partnership. And then we have Dr. Callie Tan, who is based at the London School of Hygiene and Tropical Medicine, and she's also part of the London School of Hygiene, Tropical Medicine, and Partners in Health partnership. And then Professor Sally Theobald, who's based at the Liverpool School of Tropical Medicine, will act as our discussant today. So let's begin with our overview presentation. What I wanted to do was to talk a little bit about the Gender Equality and Social Inclusion Toolkit for Health Partnerships, which was really created to help guide partners in thinking about what a GESI approach is and how they can use it and integrate it into their health partnerships or health programs. Many of the health partnerships do take a health systems perspective. So when we were developing this, we did have that in mind and thinking about how it could be integrated into health systems. But of course, the tools and guidance is relevant for all types of health programs. So here is the toolkit. It is freely available online. It's the Gender Equality and Social Inclusion Toolkit for Health Partnerships. We won't be going through all of it today because we don't have time for that. So I'll just be giving a very sort of brief overview of the toolkit, and you are very welcome and encouraged to access it online for more information and guidance around the specific aspects. But first, what is a GESI approach? So I've mentioned already that GESI stands for Gender Equality and Social Inclusion. And overall, a GESI approach really considers unequal power relations and inequalities experienced by individuals as a result of their social identities. This includes gender, location, disability, wealth, education, age, race, sexual orientation, for example, and how these identities intersect to create experiences of vulnerability and marginalization. And it really focuses on actions to address these unequal power relations. So address them in our health partnerships, for example. So, each focus on different but interrelated types of exclusion, recognizing ways in which people's multiple identities influence their lived experiences. Gender equality uses gender as an entry point to understand how women and girls are marginalized. And this is because, gender equality is something that we see everywhere. Everyone is impacted. Women, men, boys, girls, and sexual and gender minorities are all impacted by gender power relations. Whereas social inclusion recognizes that there are particular groups in addition to gender which experience marginalization and vulnerability as a result of their intersecting identities. So here are some of the activities and considerations that are included in the toolkit, and I will go through these in turn. So the first is about gaining support and buy-in, then moving into actually integrating GESI activities into program design and implementation, and then thinking about integrating it into our internal organizational structures and activities. The idea there is, thinking about if we want to ensure that our programs are equitable and lead to equitable outcomes, but we need to ensure we have equitable inputs and processes into our programs to get to those outcomes. And then also talking a little bit about monitoring and evaluation. And then some of the other tools and activities include developing a GESI strategy and action plan to help you do this. And then also assessing your activities against a GESI responsive assessment scale. Again, I won't be going into all of these today to time, but all of these are outlined in the toolkit. But let's start with gaining support and buy-in. So gaining support and buy-in is important because I'm sure, as many of us know and have experienced, not everyone is always on board of taking a GESI lens due to various reasons. They might be political, they might be cultural, they might be economical, they might be related to time. And sometimes, it does take a little bit of work to ensure that we get that support. It is something that we want to integrate throughout in our entire program and all of the activities. So it's very much cross-cutting. So in the toolkit, we do outline some arguments in support of GESI that you could use, particularly to those in leadership, and then also ways in which the senior management and leadership themselves can actively support a GESI approach. Other things that are involved at this level are thinking about stakeholder engagement and gaining buy-in at the community level, which is really important. And thinking through how we can conduct a stakeholder analysis to ensure that we're identifying key groups for inclusion and consideration and engagement, and making sure we're engaging with groups at risk of marginalization, vulnerability, and exclusion as well. So that engagement is at all levels. So moving on to integrating GESI activities into program design and implementation. So again, this is thinking about, we want to ensure that our outcomes are equitable, that they're leading to positive change, that they're reducing inequities. And the idea behind many of these activities is about doing the groundwork, doing the necessary work, so we know what are the key considerations that we need to consider when we want to integrate a GESI lens into our work, and then adapting our programming according to those findings. So one important activity that I think that we should really all be doing when we're bringing in a GESI lens is a GESI needs assessment. Another word for this is a situational analysis. There's different ways that people have talked about this. So a GESI needs assessment or situational analysis is really an assessment of the context, like the context in which you're working, in order to identify those key issues related to gender equality and social inclusion. So thinking about barriers or challenges that groups may be experiencing to participate in a project. And then also, making sure like what factors might affect the ability of our project to meet its objectives. Are there certain gender norms or other inequities that mean that will prevent us from reaching certain groups that we need to identify? So doing this situational analysis or needs assessment will allow us to think through this. And you can use primary or secondary data for this. Often we'll start with secondary data, do a desk review, using key gender analysis and social inclusion questions, and then identify any gaps or for additional questions that we need, and moving on to the primary data collection there. And in the toolkit, we do talk a little bit more about how to do this. One thing that we talk about as well, which really assists, in with doing the situational analysis. And I don't have a lot of time to go into exactly, how to go about doing this, but you will find additional guidance. This is a gender analysis, or you could be a GESI matrix. And what it does is it allows you to systematically think about the ways in which gender power relations and how they intersect with other social stratifiers lead to inequities or manifest as inequities. So through inequitable access to resources, inequitable division of labor roles practices, as you'll see on the top here, inequitable norms and beliefs, inequitable autonomy decision-making, and then how does that also lead to inequitable institutions, laws, and policies. So this matrix is really a brainstorming tool. You can do it, I've used it before. I've done a situational analysis to brainstorm what some of the key issues are. And then also you could use it for your findings to actually show what the findings are that you found. And the topic specific domains on the side here are very much there to be adapted to whatever you're working on. So you make this work for you, whereas the sort of the sex and gender specific or disaggregated data, that's really like where we want to identify where disparities might be. And then the gender analysis questions on the side here ask, kind of find out why those disparities exist and how. And this really starts to allow us to think how we might address it. I'm not going to go through all of this, but what I wanted to show you this, that in the toolkit, what we do is, I mentioned before, we take a health systems perspective. So we outline what a GESI approach is to each of the health systems building blocks. So for those of you who might not be familiar with the health systems perspective, it looks at things like human resources for health, service delivery, health information systems, medical products, governance leadership, for example, and how they all interrelate. So we take each of the health systems components, think about what a gender equality and social inclusion approach is, and then outline some key considerations for both gender equality and social inclusion. This here is just an example of human resources for health, but we include examples for each of the different health systems components. And again, this really helps to think about what are the key things we should be considering. One of the other tools that I think is very useful is after you've done the situational analysis, after you've done the sort of use the matrix, if you choose to use the matrix, and then identify key activities for integration based on those findings, you can use a prioritization table to say, what are the key activities I need to do in my programming to address the key GESI considerations I identified through the situational analysis. And this table helps you to do that. So moving on to incorporating GESI into internal organizational structures and activities. Again, this is, I mentioned before, previously, a lot of us want to ensure that we have equitable programs, we have achieved equitable outcomes, but we really need equitable inputs and processes in order to do that. And this outlines how we might do it. So basically, it's how practicing what we preach, I guess, in our organizations. And in the toolkit, we go over what each of these are. Some examples include developing a GESI statement and making sure we're integrating a GESI lens into our own internal organizational policies and procedures, making sure we have specific training for our team members, identifying and supporting GESI champions, and then also in thinking about who's in leadership in our organizations and who might be missing from that. So moving on to the monitoring and evaluating GESI related activities. One of the toolkit goes into more examples of this, but thinking through, what is a GESI responsive indicator, and we thought about it in terms of sex and gender disaggregated indicators and social inclusion indicators. So this helps us think about, we've identified our key considerations. Now, how do we measure that in our work? And this will help us think through that. So you can see that there's a difference between sex and gender specific, and sex and gender disaggregated indicators versus gender equality indicators. So if you think back to that matrix, the sex disaggregated column, that's where you see those first two indicators. So that pertain only to men or women. And then the sex disaggregated looks at differences between men and women, whereas the gender equality looks at the ways in which gender power relations manifest, and similar for social inclusion indicators. In the toolkit, we outline how you can create a GESI indicator sheet as well to outline and incorporate GESI into your monitoring and evaluation plans. We also outline, thinking about, after you do all of these activities, actually developing a GESI strategy and action plan with key activities that you'll do. And this provide a table of what that might look like as well in the toolkit, as you can see here, with key measurements and thinking about who's responsible for which activities. And then also provide guidance on, when you've done all of this, how can you assess your activities against a GESI responsive scale. And we provide that here, which is based builds off the WHO gender assessment scale. So looking at gender and equal, GESI and equal, blind, sensitive, specific, and transformative. And again, we go into more detail in the toolkit about this. But as you can see, GESI and equal perpetuates inequalities. GESI blinds ignores them. The sensitive approaches acknowledges but don't necessarily address, whereas specific considers and addresses inequalities, and transformative aims to actually transform unequal and harmful inequalities. And GESI responsive policies and programming we find on the far side there. And we have a checklist in the toolkit that you can think through, what am I doing, and am I doing these key activities in my programming? So that is the end of that presentation. Really just wanted to give you an overview of the toolkit, some tools and guidance around how can I integrate a GESI lens into my approach. What we want to do now is turn to our panelists who've actually done this, who've worked on these health partnerships and integrated a GESI lens into their work, and hear from their specific examples. You'll hear a little bit about their partnerships and their examples of how they actually went around and integrated. So what we're going to start with, I have a few questions, and we're going to start with Dr. Callie Tan and Matthew and Nime Ramana, and then we'll move to Dr. Yusuf Ardo. So Callie and Matthew, if you could please, and from your perspective, be interested to hear, why do you think GESI should be integrated into health programs? Or even, do you think it should be, and why do you think it should be? So maybe Callie, we can start with you and then hand it over to Matthew.
Thank you, Rosemary, and thank you very much for having me today. You know, we work in maternal, newborn and child health, and the integration of GESI into our programs is absolutely essential. More broadly, I think we always have to think about how do we increase the likelihood of the maximum potential of our programs and the impact and reach of those programs. And in reality, those who are the most marginalized often are those most in need. And in many societies that are patriarchal, that is women. And we also work within our programs, of course, with children with disability, and I'm going to talk a little bit about that later. But the discrimination and exclusion that women experience through having a child with disability further impacts their ability to access services and care. And so, you know, it's really, really important for us, but for programs more broadly, I think, to really understand who is being excluded from your programs, how they are being excluded, and an approach to adding agency for those groups that are being discriminated against, and improving their access and impact for those individuals. We are very lucky that the SDG sets this out for us. The SDG sets out to leave no one behind, and you know, explicitly endorses gender equality within that, recognizing this really important role of women and girls, and a focus on women and girls in programs. So, you know, I think across all programs, but, you know, particularly programs like ours working with women in disability, a gender lens on what we do is absolutely crucial.
Thanks, Callie. And Matthew, from your perspective, do you think a GESI lens is needed? And if so, why?
Thank you. I think it's fundamental for any programming, particularly for health programs. As Kari was saying, this is so helpful to just ensure that men and women are fairly or equally accessing interventions. But also this is to ensure that as we do program interventions, we are also engaging and ensuring that no one is excluded. Particularly to our area, we are working in maternal child health, where both men they play a great role. So to ensure that there is an impact to the child development outcomes, this requires all involvement of fathers and mothers, and also the society as well. So it is very important to understand what are the barriers that are affecting the GESI, and so that we can address them. So this also require for the programs to understand each society and the societal norms and the practices and any challenges that the society are having, but also by ensuring that the community, all participants, men and women, are understanding the GESI principles, and then I include that into our programming. Thank you.
Thanks, Matthew, and thanks, Callie. So just to stay with you for now, could you give us some specific examples of how you've integrated a GESI lens into your health program?
Maybe this is a good chance for me to just explain a bit more about our program. So I've just got 2 or 3 slides to just, might be more than 2 or 3 slides, actually, might be 4 or 5 slides, but just to explain a little bit more about our program to really frame. Can you see my screen?
Yes, we can.
Okay, I'm just gonna, how's that?
Yes, great, thank you.
Just to outline our programme, we work within early care and support for children with developmental disability in East Africa, and I'm going to give you just a brief overview of that programme, and then Matthew, who is our programme lead in Rwanda, will give a much more personal understanding and appreciation of the programme as it runs in Rwanda. Obviously, you know, with a global perspective on early child development in the era of sustainable development goals, there's this renewed emphasis on maximising developmental potential for all children. But all children are embedded within a family and a wider community. And we have the global strategy for women's, children's and adolescents' health that supports these 3 pillars of survive, thrive and transform. And I think GESI really comes into this transforming communities to really embed within our communities the full impact of the programs that we are implementing. There is an estimated 53 million children with developmental disability around the world, and in many countries families with a child with disability are exposed to discrimination and exclusion, and a lot of superstition and stigma around disability. Primary caregivers are most frequently women, of course. They're frequently marginalised by the discrimination and exclusion that they face in relation to child disability. So that's really a background on where our programme comes in supporting, providing early care and support for children with developmental disability. And the programme is a facilitated participatory group programme it runs over 10 or 11 modules for families to provide early care and support. And there is 5 kind of cornerstones, if you like, or principles of our programme. And the programme is called Baby Ubuntu. Ubuntu is a Zulu term, actually, that means a sense of togetherness. It's a sense of I am because we are. And really embodies the approach of this programme. So we aim to promote inclusion and participation of children with disability within the family and community. So this is really a social model of care as much as it is a medical model of care. We aim to maximise a child's developmental potential, optimising health and quality of life. A really crucial component is empowerment of caregivers through information sharing and peer support. And in order to do that, I think we need to understand the child and family experience, and particularly addressing stigma. And I think this is crucial, specifically with the gender lens, to really understand the lived experience of the women accessing our programme, and of course promote human rights of children with disability. And the programme this is Praise and her family here, the programme was really developed in a grassroots way up. So it was developed by expert parents of children with disability, originally in Uganda, and now the progress has been rolled out across Uganda and Rwanda. And our expert parents are still really, really crucial to that perspective. So the content of the programme is very developed around the needs of a child with disability. You see here in the top left corner, and I'm going to come back to this, a father accessing and attending our clinic and learning how to feed a child with disability. We look at positioning, communication and play, but the most important picture here is the picture in the bottom right hand corner. This is about peer support, it's about shared learning, it's about community mapping of services, and it's about sort of learning to grow together in your lived experiences of caring for a child with disability and continuing to care for them and provide a network of support going forward. So the power is in the peer support. The group aspect provides that peer support and sharing. Mothers tell us that it raises their confidence, their respect, improves their knowledge, and really importantly, reduces their self-stigma, which can be quite profound in some of our communities. It gave me confidence and I got to know what happened to my child, and I appreciated the fact that I was not alone. This is Betty. Betty is one of our expert mothers, and I think this is one of the really key ways that we bring a sort of a GESI approach to our program. It's through our expert caregivers. They are our most important stakeholders. You know, this is just a comment from one of our expert mothers. I've shared my experiences, and through sharing, others have trusted me, and they share me with their experiences. And this gave me hope that my child will get better too. The experience and interaction with other mothers and their disabled children gives me confidence. I've been able to relate freely with others, and it has reduced my stigma. We have important cross-cutters throughout the programme. I've talked about stigma inclusion and exclusion. We're here today to talk about gender. Primary caregivers are frequently mothers, but fathers are decision makers, gatekeepers, and often provide the family finances. So it's really important that we also engage and empower men within our programmes and to really maximise the impact and reach of what we're doing. Literacy and poverty are really crucial barriers for women as well, and I think that also comes under our GESI lens of thinking about how being intersectional in thinking about how these things also influence the reach and accessibility of our programme. And of course, you can't really ignore the impact that COVID has had on isolating families and the challenges that we've had to overcome to think about how do we still keep these facilitated group activities coming. Supporting women to work is really important, and we really enable that through providing a sort of momentum for livelihood support, but also women working together to see how they can support each other in returning to work with child caregiving, but also with taking their child with them out on their daily activities. And finally, really the role of fathers, and Matthew can talk much better at this than I can, but you know, women with a child with disability frequently marginalised and lack agency. Fathers are decision makers in accessing services, and abandonment is common for women when they, or for families really, when a child with disability comes into that family. Understanding the role of fathers is really important. Engaging with them and empowering them to stay and to engage with their children is really crucial. And we have started to introduce expert fathers as facilitators for our programme as a way to really transition and transform our groups and our communities to promote inclusion and participation for families and children with disability. So that's just a very brief overview of, I think, how gender equality and social inclusion is embedded within what we do, and just a thank you to all of our collaborators, teams and funders who support us. And I will hand over to Matthew to talk probably more from the programme perspective on how GESI is really embodied within our programmes.
Thank you. So the program itself is developed in the way that it focuses on social inclusion and gender equality, and by empowering mothers. So I'm just going to talk about how we just started. We had like some challenges one of the challenges was related to cultural norms, where in our society, it's a patriarchal society where responsibilities are normally from only men. And as Kari was mentioning, there are different cross-cutters where responsibilities for caring a child is left to the mother. And this is challenging if the family has a child with disability. Now this brings more other issues like stigma and finding fathers leaving their homes, separation, and the gender-based violences. So when we started implementing this program, we had the focus group discussions with mothers, with fathers, and with social workers and the care providers, just to inform us how can we address these barriers, these challenges that we know our society has. So they have provided a good way of just inviting fathers at the first sessions so that they are informed on the program. And we have had groups where fathers have been coming to all sessions, and they are now acting as change models, as key agents in the community by just being champions to just convince, to just mobilize other fathers to understand the needs of empowering fathers, but also their responsibilities in the responsive caregiving of their children. Secondly, we had the expert parents who are the fathers in the program, and this is like new model, and it has changed the society to on the beliefs, misperception that they have on the roles of fathers, and this is just helping us for people to just understand this is possible and changing the community. And also within that, the program that we have also men, and also we have women that are employed. We have the peers where expert parents are working together with care providers. And this also brought the perspective, and though there was resistance at the start, but we have tried to just have discussions on the importance of equal partnership where mothers share their experiences. And for us as care providers, we don't understand where there are challenges because we tend to focus more on health and not focusing more to the social. So this is social model, medical model program that this now has brought us. We have many people reporting that this is helping the healthcare providers normally to just understand gender issues and then addressing those issues, helping the families to address the gender issues. But also the expert parents also feeling more empowered, and they are now acting as an advocate for change. And our country has strong policies, but we have like some more cultural norms that normally impede the policy to be implemented. So this has been one of the opportunity for us to just to just give feedback to policymakers on the best way that we can use to ensure that these policies are enforced, and making sure that the laws of men's and women's are equally are fairly ensuring that men and women also are accessing the health services, but also by ensuring that there is increased fathers, the engagement of fathers is seen in all programming. Thank you.
Great, thanks Matthew, and thanks Kylie. That was really interesting to hear about some of the key GESI related considerations in your program and how you integrated them and addressed them. We're now going to move to Somaliland and hear from Dr. Yusuf Ardo. So Yusuf, I have the same questions for you about why, in your opinion, is a GESI lens important, and how have you integrated them into your health program? And I know I will go ahead, just give me a moment and I will go ahead and share my screen.
Thank you very much, Rose. And hi, everyone. And first of all, I want to just give you an overview about the gender and Somali community in general. And yes, the next slide. Yes, that's really very important. And really, I want to highlight that when it comes into gender issues, it's not really a very simple issue that, but the gender is very, very complicated, and there is a multi factor that affect the gender throughout the world. And even within these factors, the contextualization really is very, very important. For example, if we are if you have the religious scriptures that handles the issue of gender in Saudi Arabia, can be interpreted differently from Pakistan, from Afghanistan, from here in Somalia, and so on. So the gender has this really different and complicated dimensions, and it's not easy thing. In recent history, the gender issue is strongly present in all discussions in health, in politics, in economy, and so on. And here in Africa, actually, the lessly, but in the Western country has complicated more, since we are not talking about the male and female only. There is another type of gender emerging in nowadays. Let's go to the next slide. In general, in Somali community, and if you look the history and the literature, you will see that Somali society routinely gives the woman a very good position. And the role of woman was not limited to child raising and homekeeping, but women have actively participated in decision making and in public issues like conflict resolution with the community, and have historically had political positions. And there is a evident patriarchy within our society, and we will explore overcoming these cultural limitations and religious misconceptions within the following slides. Please go to the next slide. This is really a Somali queen and around the 15th century. And this is really an indication on how Somali woman really was even at the highest rank of political ranks in Somali society. Please go to the next slide. And despite all mentioning position of women in society, still the Somali community considered as a patriarchy. According to not only in the culture and that aspect, but population-wise, Somali have the population made up of 51% of men and 49% of women. Somali people are traditionally nomadic, which is really a very difficult life, and heavily relies on outdated gender roles such as being homemakers, mother, and wives. And often following wars within developing countries, social transformations occur even within Somalia, having been subject to a newfound post-colonial political dynamics, civil war, and tribal conflict. The gender roles have undergone several changes, and this gives the male some advantage, particularly political prestige. Can you go to the next slide, please? And right now, after the Second World War, the Somali community in general undergoing a comprehensive social and political and economical transformation, but really very, very slowly. The first girls' school here in Somalia has been established by the British colony in late 1940s. But till now, the boys' enrollment is very, very higher than the girls. And what is really very impressive that in the last 2 decades, the enrollment of girls into a medical education was very heavy, and this resulted that the females dominated in the fields of nursing and midwifery. And through this, we can really achieve the gender equality through a provision of practical measures, health and social care, education, politics, and so on, that can create an enabling environment for men and women both, thereby enabling women contribute to sustainable development within Somali peninsula. Please go to the next slide. And if you have a look, this is my city, the medical school, and you see that a very quite good number of girls are in class 2 medical school. And this is really a very good indication that if we go into the next 2 decades, the same in the year 6 class of medical school in Borough, the number, almost equal numbers of male and female are graduating the next year. Please go to the next slide. And there is some challenges. I think we should mention in the next slide. Please go to the next slide before we. Yes, the poverty and by the nature of the Somali society is really a very difficult society with the cultural limitations and religious misconceptions, and very difficult to transform easily. And the Somali society normally, they don't believe in science. This is a very big obstacle. The literacy rate is very high, above 50, especially among women. And extreme poverty really is one of the biggest challenges against GESI program. And please go to the next slide. And in our partnership, Borough-Wolverham partnership, this is really a new partnership, and we want to focus on the non-communicable diseases, which is a very big problem here, a newly emerging problem here in Somali society. We have a very clear policy toward the GESI, and we want to include the women and the people with disability and those from disadvantaged background in the project design and implementation from the beginning. And we think this will ensure that their needs are taken into the concentration from the time of the project design. And this is exactly what happened. We will stratify the project monitoring data based on the gender, age, social status, and disability. And we will monitor this closely as the project proceeds to ensure that everyone is served fairly and with equity. We adopt a gender-neutral recruitment policy, and we will include a non-discriminatory policy in MOU between us, University of Quran, University of Wolverhampton, to be signed by these partners. We will give a concession to women and people with disability and those with disadvantaged background when allocating slots for continuous professional training. And I think this is the last slide. Thank you very much.
Thanks very much, Yusra, for providing that really interesting contextual background, thinking about key challenges when we're integrating a GESI lens, and then thinking about some of the key actions that you are doing in your partnership to do that. So what I'd like to do now is, before we move on to Sally, Professor Sally Theobald, who will kind of be our discussant today and provide some reflections on integrating GESI into health programs, just to let Callie, Matthew, and Yusra, any sort of final words from you, any final reflections you may wish to add. Yusra brought up some interesting challenges in the Somaliland context that had to be overcome. Were there similar challenges in your context, for example, you may wish, or, just to allow everyone, give everyone a minute or so, sort of a final thoughts and reflections before we move on to Professor Theobald. So Matthew, maybe I can start with you.
Thank you. I think as the highlighted, GESI is so important, and it depends on the context. Each context has a different aspect to consider, and then come back to the Somali. So we had like some of the similarities. One of the things that I had is from a historical background, the roles of women. Sometimes we need to consider them because this can help in ensuring that the society is so understand that doesn't bring other misconception to their role that they contribute. But however, also we need to see or how that is not also excluding, not used as excluding, because we had some kind of same challenge in here, where we just say, oh, women are in this. We have like in our country, women are represented, are highly represented in the government. So we have a government that has a lot of women, but looking at to now implementation side, we found also there are other challenges that needed to be taken into account. Though we have that higher representation at higher level, and also though we have these roles that in the community, but we still have also to consider the challenges that are so important in terms of ensuring that there's great impact, particularly in the area that we are working in, where the aim is that to ensure that children survive, thrive, and achieve their developmental potentials. Thank you.
Thank you, Matthew. Callie, can we move over to you next?
Yes, thank you, Matthew. I think Youssef highlighted, and you highlighted in your talk about the need for, apologies for my puppy in the background, the need to integrate GESI into your policies. And I think once they're there in your policies and in the way that in your agreements within your partnerships, it's really important that you follow through on that. And I think one of the important challenges we've seen, for instance, which, really crucial to our model, is this expert mother who co-facilitates our program with a healthcare professional. And we are very clear that they need to be trained together and that they have equal standing, because they bring different experiences to the facilitation role in the program. And the mothers bring a lived experience and a form of peer support that cannot be replaced by a healthcare worker. And we sometimes, to talk about challenges, sometimes we find that new partners don't really understand that role very clearly at the beginning. And it takes us time to convince them of the importance of the expert mother as a facilitator and as a core stakeholder in this program. And, you know, when we think about that and what we can do about that, we can show examples of our work where they can see this working, but also we make it non-negotiable. And I think that's really important. You know, we say there is no role for this program without the expert mother. She is crucial and a core to this program. And so if people are not prepared to take on that model of expert parent as a facilitator, then we don't collaborate on the program, because we consider it absolutely key, and it's absolutely key to our GESI strategy. So I think there's a bit of taking people with you, but I think there's also a bit of saying this is our policy. We believe in the importance of gender equality and social inclusion, and we will follow through on that. It's not tokenism, it's important, it's at the core of what we do, and we will always follow through. So I think that's really just an example of some of the challenges that we see and how we overcome them.
Thanks, Callie. And Yusra, have any final reflections or thoughts from you? And then you're on mute if you are speaking. Yusuf?
Yes.
There, great. Can hear you now.
Yes. Really, it's the gender issue, as I mentioned in the presentation. It's really very challenging, and in Somali community, it's really when it comes into the health sector, really it is challenge, but through these policies and this within the new partnership, I think we can overcome all these challenges, and this slow social transformation that are undergoing right now. The situation might improve in the coming 2 decades. I want to be optimistic, really. Thank you.
Great, thank you very much. And I think from all 3 of your final reflections, there are some things I really picked up on. Was the sort of the need for these policies and procedures, so these action plans, and then following through with them and ensuring that it's sort of a key component of the work. So our GESI action plan and integrating GESI into our policies and procedures. So we are going to hand it over to Professor Sally Theobald now, who will provide some reflections as she's doing. So please do think of some questions for our panelists today. Do put them into the Q&A. If you do type, we can see them if you put them into the chat as well. So either one is fine, but please do think about questions, and we're going to have about 20-25 minutes for Q&A at the end. So Sally, over to you.
Thank you very much, Rosemary, and thank you to the fantastic panel. I've been given this challenging job of trying to summarize, wrap up, think about the way forward, reflect on what we've learned, and it's been really rich, and I've been taking lots of notes, and what I want to do is to summarize my thoughts and my learning into 3 bullet points. So number 1 is about where are we now, and thinking about the implications of COVID-19 pandemic, but also the aid cuts we've seen brought into the UK earlier this year. Second comment is around the importance of context-embedded GESI analysis and action. And my third comment is around health programs, health partnerships as being strategically positioned to drive forward GESI, both internally within our systems and structures and externally. And we've seen some and heard some really inspiring examples about that today from Rwanda, from Uganda, because you said you rolled out, and also from Somaliland. So I'm going to go through them one by one. So first of all, in terms of the changing context. So I think we all benefit from health partnerships, health workers in low and middle income countries, health workers in the UK, patients and communities. And so for me, it's particularly tragic that at this time of a real interconnected world, COVID-19 has shown the ways in which our world is interconnected in so many ways, has highlighted the importance of solidarity, that we are seeing aid cuts from the UK government. And due to cuts to UK aid funding, the THET UK Partnership for Health Systems has had to terminate early, with minimum activity ongoing up until February 2022. And THET colleagues are working really hard to actively seek out alternative funding sources, and has already been possible to seek funding for some. So I want to thank and acknowledge THET colleagues for working in this way. And also to think about COVID-19, and we've seen different commentators talking about COVID as an X-ray or a portal or a window into inequity, and also amplifying inequity in complex ways. So now more than ever, I would argue, GESI is so important. So the context right now is a context where we need to drive forward gender equality and social inclusion, and we need to share learning and support each other. And this webinar is part of that. So sharing learning in this important area. So my second comment then is about this context embedded GESI analysis and action. And all contexts are different. Health issues are different. And Yusuf, you gave us a brilliant overview of how gender equality, social inclusion can change through time. And I learned from you about the real active participation of Somali women through time, the Somali queens, how colonialism and war has benefited men to certain degrees, how it's evolving, it's complex. And because of that, that's why we can't just cut and paste gender equality and social inclusion from one context to another, or from one health issue to another. We need to do that GESI analysis. And Rosemary, I thought your presentation of what's in the toolkit was brilliant, inspiring, and it is a really good resource. And it's a resource that helps us, to use Callie's words, to follow through, or what we've seen in the gender and gender mainstreaming literature is this potential for evaporation, right? You might have beautiful gender indicators or social inclusion indicators or a focus on disability, but it might evaporate in practice if we don't keep returning to it. And that's what, to me, is really powerful about the GESI toolkit, right? We've got strategy action plans, we've got indicator sheets, we've got ways to monitor, we have got the GESI responsive assessment scale, so that we can keep looking through time and analysing where we've got to, looking at how we can improve. We've got practical ideas about how to get buy-in within institutions and within partnerships. And as Rosemary said, health systems approach. Health partnerships work within health systems, so that holistic health systems framing across those building blocks, but also with a focus when appropriate on health emergency and responsiveness. So indicators that we can think about through that. So if you haven't looked at it, do look at it as a tool to support ongoing buy-in partnership for GESI. Okay, so my third and final comment is about how health programs are strategically positioned to support gender equality and social inclusion. And I think we come into contact with health programs across our life cycle more than any other institution. So health programs then are strategically positioned to support or enable gender equality and social inclusion. And what the tools do, and what we've heard from our panelists, is how we need to do that at all different levels and how these levels interconnect. So, for example, we need to look within as institutions, as partnerships, and look at how we operate. And there's nice guidance and ideas in the toolkit there around human resources for health, around institutional policies and processes, around structures and responses for sexual and gender-based violence. And Yusuf, you outlined that in your partnership in terms of thinking about gender equality and recruitment policies, ensuring non-discrimination is embedded in MOUs across and between different partners. And then also in our core business, in our service delivery, in our community engagement, and I think we heard that really clearly and loudly from the Ubuntu project, in terms of focusing on the expert parent, on the mother, on the father, on the social collective of learning from each other, and the importance of empowerment of caregivers, and the importance of peer support and shared learning, growing together, supporting each other. And Matthew, you talked around engaging men in that process and men as champions to mobilize, to demonstrate responsibilities of fathers, and how this in turn has changed societal norms. You know, that's an example of how health programs with GESI embedded in their heart can be part of this broader focus on gender equality and social inclusion within society. So I found that a very inspiring example. So please do look at the toolkit, think about how you could apply it in ongoing health programs. It's a resource that also has lots of references. There's been really good learning and reflecting and sharing here. So we need to keep doing these gender equality, social inclusion analyses because contexts change and COVID has brought new vulnerabilities. Groups that may have been less vulnerable may become more vulnerable. And Callie, you talked around isolation and as an impact of COVID, you know, how easy is it to bring people together? So COVID has changed the world on lots of levels in terms of how we interrelate. So we need to keep adding and doing these analyses and assessments and embedding them into our programs. So lots of advice, ideas, tools in the toolkit and from what you've heard from the panelists. So I hope you've been inspired to bring that GESI lens into what we do. Thank you. Back to you, Rosemary.
Thank you, Sally. Thanks for the reflections and excellent sort of wrap up of some of the key points. So we're going to turn now to the audience questions. And Callie, Matthew, and Yusuf, if you could, if you're able to, if you put on your video cameras, that would be great. But we understand that's not always possible with connection issues. So only if you're able to, just so the audience can see us when we're responding. We have a number of really great questions coming in, and I'm going to try to, so we can get to as many as possible, group some of the ones together that are similar. So we have a similar question from George at Tim and is it Piradas? Piradas is George says, thanks Callie, Matthew, and Yusuf for your presentation. Could you share your experience securing buy-in for GESI? What were the critical levers of influence and conditions within your organizations and partners that enabled the integration of GESI? And Vera asked a similar question about how have the panelists sought the buy-in of the governments of GESI and what has been your experiences? So I will open it up to any of you who would like to go first. Then I will call on one of you to go first. I know no one wants to take over for someone else.
I think Matthew's unmuted, and then I can.
Perfect. Matthew, please go ahead.
Okay, thank you. My internet is unstable, so I won't be able to put my video. Our government has been sensitive to reinforcing gender equity. So Rwanda is among the first countries that has gender reinforcement policies. And also we had the gender monitoring office that monitor indicators around gender equality. So this has been like opportunity normally to just share what is happening on the ground. So we have a national technical working group, various technical work groups, but the Ministry of Gender and the Family is the one that is mandate to implement the ECD, Early Childhood Development Policy. So that's where we fall. And we meet regularly to share the challenges, and they can also run on these challenges around accessing health services, and also the gender issues and challenges that are experienced by families with children with developmental disabilities. So we have been sharing them, our implementation, and but also the challenges, and they have been also running on how they can be enforcing the policies. So over the country now, they are also addressing and reinforcing the policies that we have, and also ensuring that our early childhood development programs that are being implemented, also they do also address and integrate gender transformative interventions. So secondly, we also work at district level, where we meet with all partners. So I've been having also task force meetings. These all partners share all their experiences. So we work in 2 districts in the eastern province of Rwanda. So we have been discussing with them on the best way they can also help us, support us. We can jointly work together to address on these issues, mainly social protection, because the issue of stigma and exclusion, they need also the support from the government to ensure that no one is excluded, and also families, children with disability, and all families are equally treated. So that's there has been a good learning experience, and we have been receiving positive feedback and learning. Thank you.
Thank you, Matthew. Yusuf, do you have any reflections on gaining buy-in from Somaliland? And just, there are some other relevant sort of questions for you, I think, that you could address when you're speaking to that, because I think they all are overlapped. There's a question from Amal about what helps you to implement this kind of project in Somaliland related to gender and inclusion. As we know, there are norms, beliefs, and religion around misunderstanding and overall country law. So like those are some of the sort of key challenges. And I think that's very much related to buy-in, gaining buy-in for GESI.
Thank you very much. I think the government of Somaliland in general, it's going to the direction of the gender equality. And we have almost 3 or 4 ministers now at the cabinet, and the government, the public sector employee are there is a quite good number of women and the marginalized groups also, and the people with disability. And but I think there is some historical issues that prevent the real equality to take place here. But I think in the coming 2 decades, as we are seeing the environment here, there will be a lot of improvement when it comes into GESI. And I think there is some question from someone, I don't know, is talking about the male respect, if the male doctors, they respect the female professionally. This is a really very interesting question. And I want to talk about, because this, if you, in 2016, a quite number of Somaliland women go outside the country to visit doctors in Turkey and India. And statistics shows that this cost the country $60 million US. And why this? Because the woman, almost the medical field was traditionally here was a male-dominated environment. And when the woman, they may go to the doctor and at the same time refuse to be examined or to expose their some parts of their bodies, or may hide some very significant information at the level of history. And at the end, this will lead to a misdiagnosis or under-management of their diseases. And this may create the need to go outside the country for a long-standing issues, for example, gynecological diseases. I think this is all what I want to say here.
Great, thank you. Callie, there's a question here around from Pyra, sorry if I'm pronouncing your name wrong, is about what the kind of timelines are required for GESI interventions. I don't know if you could speak to that.
I think Sally has really, really well identified that it is context specific. And I think it depends on your program. I think it depends on where your program is functioning. I think the need to make an evaluation of like a situational analysis is the starting point. And I think only then are you going to be able to say what the timelines are. What I would say is start at the beginning. Don't bring it in later. Start at the beginning with a GESI lens on everything that you do. It's not something to be integrated later. I think it has to be at the core of the development of your program, and that's what we found. Will we be developing and scaling up this program more and more over the next 20 years? I hope so. And our context will change and our partners will change, and we aim to be responsive to that. So I don't think there is a fixed timeline on it, but I do think the time to start is at the beginning, and the time to do your situational analysis is at the beginning, and then think about how you are going to act on your GESI strategy. And I think that's really the core component on timelines, really. I don't know if Sally can speak to that more clearly than I can, but.
Great, thanks, Callie. There's Matthew, there's a couple questions here for you, which I think are interrelated. One is around from Lillian about, in Rwanda, is the ministry supportive in terms of policy implementation and monitoring to enable GESI? For example, the SDGs leaving no one behind. And Evaristo asks, how is the program design in Rwanda ensuring that the marginalized at the decision or at the decision-making table with the structure of the project? So one question around sort of how are you ensuring that the marginalized or have a seat at the decision-making table and have the support, how supportive is the ministry in monitoring, enabling a GESI perspective and lens.
Okay, thank you. So the first, I start with the last one. So the ministry has a gender monitoring office which is independent office. Normally that does monitoring for implementation of a gender policy. So that's for the country. So regarding now for the policies, I was saying that we have many policies that are enforcing gender. And also gender equality, social inclusion from the constitution level to the policies, particularly that for gender policy and policies that around child development families, they also enforce the gender equality and social inclusion. So the government is so supportive and sensitive to that. From the government level, I was saying that the women are highly represented, and also for the community level, so women are represented. So, however, we do have challenges, as I was explaining, and those challenging, as we identify them, and we discuss on the way that can be addressed, always the government is supportive to that. And we meet through the forums of technical working groups and also work from the local leaders level and the local government, which is the district. So how now vulnerable people are given voice from the political level? The constitution enforces that they are represented at parliament and different levels, whether they are depending on the vulnerabilities. But for our program, one way that is innovative is just to the expert parents model. This has given a voice and a new way where you ensure that people normally are freely can advocate and are empowered, and can also use this peer support to make sure that others also are empowered. So this is one of the innovative way that I found. And in the program, we have modules where we invite local leaders, opinion leaders, and different people from the community who can just contribute to the change. So it has been a good experience to learn that this mother who was having stigma, who were hopeless or depressed, being the one normally educating, preaching the human rights to the local leaders, and local leaders also understanding, trying to reflect, and also just making a decision that now I'm going to support. Thank you.
Great, thanks. Thank you, Yusuf. Oh, sorry, thank you, Matthew. Yusuf,
I don't know if I've,
yes.
I don't know if I missed any question.
Oh, that was great, thank you. Yusuf, that's why I was for thinking ahead of the questions I wanted to pose to you. There are two questions here I thought that might be good for you. One is from a Mim about what have you seen that's been effective in bringing male leaders to be active allies? And then there's another question from Roham about, they say that you talked about the gender ratio among nurses and midwives, and do you think it's a marker of gender equality when women integrate the medical profession at the non-physician level? And what about sort of looking at the ratio between physicians, non-physicians, health workers, between men and women? Is it improving? If you can speak a little bit about that. And then also, as I mentioned, the question around bringing male leaders to be active allies.
Thank you very much. Yes, the ratio is going to, it's improving really. And we are created nowadays the field, some fields like in nursing and midwifery, is dominated by females, and this is a really good indication for GESI program here in Somaliland. And really, we are in this partnership advocating to have advisory board for our partnership, and this advisory board from the community leaders, and the community leaders have their influence on the political aspect. And at the end, I think of this, we will have some male leaders that strongly support the gender equality and social inclusion programs. Thank you.
Thank you. We're getting close to time, and we're not going to be able to get to everyone's excellent questions. I have saved one of the more difficult ones for last, and I'm going to start with Sally. So saving the difficult ones, and then allow anyone else to kind of jump in. There's a couple questions that are kind of interrelated. One is from Carrie, and another one is from Tasmia about sort of the difficulty of integrating GESI in, like there's some really difficult issues that sometimes we have to deal with, and working in difficult context, things around where, you know, LGBTQ issues might not be recognized or even legal, that sort of religious beliefs could be seen as harmful towards GESI approaches. And then also thinking about really Tasmia's questions is really about ingrained sort of gender norms, and they provide an example from Southeast Asia about the mindset of prioritizing men over women in the family, and how do you tackle really ingrained mindsets. So it's like really, I think both of these questions have to do with how do we deal with these complexities and difficulties in relation to GESI. And Sally, I'd love for you to start us off, and then allow Callie, Matthew, and Yusuf to add any final reflections on that. So.
Okay, thank you. So these are really complex, challenging issues, and often GESI is about challenging and changing norms, and it's not easy, and I think we should recognize that it's really not easy. But as we've heard, you know, Yusuf talked about how, with the example of gender, how that has changed through time. So these are social structures, norms are social structures, they do change through time. And I think our role in the health sector is to develop strategic alliances to promote change, whilst prioritizing safety and safeguarding of differentially vulnerable groups. Think critically about how to try to bring change and allow difficult issues to be talked about. Think critically, use your gender GESI analysis to look at stakeholders, where their positions are, where there's room for maneuver, what arguments, what strategic alliances are most well positioned to bring change, bring different voices and different perspectives into that debate. Be brave, but prioritize safety and safeguarding too. And that can be a difficult tightrope to walk. And I think they're very good questions, and I look forward to the others' views too. Thanks.
Thank you, Sally.
I think for us to talk to that, for us, it's been about engaging with fathers. That actually some of the most important GESI work we do is engage with fathers as much as mothers. And what we find is when we do engage with fathers and we get that right, and the way that we need to engage with fathers is often different to the way that we engage with mothers. But when they do, they can become our strongest allies and our strongest advocates. And they can often, as much as men or as well as women, be the center of transformation in the community. We have children with disability, we have fathers who have been in our part of our program that have just through the engagement with one father transformed our communities, that their child has become a focus for understanding disability in their community, because they can be incredible champions. So Matthew can talk to it better than I can, but certainly within our Ugandan setting, we've just really found being strategic in who you engage with. Don't be not being single-minded in the way that we engage. The way we engage with mothers is often different to the way we need to engage with fathers. Listen very carefully to the leaders in that community as to what will work, and work very closely in partnership with communities to understand how to action those changes and how to give agency or support agency in the most marginalized groups to make that change. But I would also echo Sally's point about safety and safeguarding. Our children and our mothers are vulnerable at times because, and the peer support provides them with a network on which to advocate. And I think it is about empowering them to do that, but doing it in a way that's safe. And I agree that that balance is sometimes difficult. That line is quite difficult to walk, but safeguarding is also a core component of the work that we do with that regard.
Thank you, Callie. And Matthew and Yusuf, any final reflections from you?
Well, thank you. It's just echoing what Callie was saying, working together from the start, and just using this participatory approach and giving information, because some don't have this knowledge, so that now they can participate in providing the approaches that can work, and how can also change also the structure of the community and these cultural norms. Yeah, so thank you.
Thank you. Yusuf. Yusuf, you're on mute if you're trying to speak.
Mm-hmm. Yes, I want to, before we begin the session, I want to highlight a very, very important issue. That some people, they may think that the religion is against the gender and equity. We really was working with the Islamic research centers here to what is the obstacles, what's this misunderstanding for the religious scriptures, which accumulated really with the time, and it needs some time to deal with it. But the religion, as our scholars here prove so many times, it's not against the gender equity. But some people, they may understand that when we are talking about the gender equity, we are talking about something, we are talking about the, for example, lesbians or guys or something like that. We are not in health sector. Gender equity is really nothing to do with this. We don't want to mix all this. Since all of them, they carry the name of gender, but really the religion is supporting this very important issue with gender and social inclusion. And really we conduct several seminars, meetings, and even these researchers are coming, furthermore clarifying that the religion is supporting the gender inclusion, and against all the violence, all the discrimination against women. This is really a very important point, should be highlighted before we end this session. Thank you very much.
Great, thank you, Yusuf. And so what I'm really hearing from everyone is really the need for context-specific approaches, for thinking, need for safeguarding, working within also sort of institutions as well, and to advance GESI goals. So thank you everyone for coming today. thank you, Callie, Matthew, Yusuf, Sally, for your time, for presenting today and sharing your valuable experiences. For those that are still with us, we will be sharing the recording. We'll also be sending out a short sort of webinar evaluation that we'd appreciate for you to fill in as well. And yes, thanks. And if you have any questions, please feel free to reach out at any time. And we've also shared the link to the toolkit in the chat box. So thank you, everyone, and enjoy the rest of your day wherever you are in the world.
Thank you very much.
Thank you, Rosemary.
Thank you, everyone.